Now, the purpose of my presentation is to discuss the diagnosis of intra-abdominal hypertension and abdominal compartment syndrome, discuss early management strategies, emphasize the need when surgery is needed, and highlight options for definite abdominal wall reconstruction. In other words, encouraging surgeons to close the abdomen before the patient goes home, and make sure the patient does not have to stay with an open abdomen or a hernia for a long time. Now, this concept evolved in trauma surgery, especially in damage control, where the Moore brothers in Denver found that some patients were so sick after trauma, they could not close the abdomen, so they left the abdomen open, and lo and behold, those patients in whom the abdomen was left open are the ones who lived. And that has now expanded to conditions like peritonitis, aortic aneurysm, pancreatitis, burns, organ transplantation, obesity. And anytime you resuscitate a patient, you have blood in the abdomen, you have intra-abdominal hypertension. In my 12-bedded ICU, actually 14 beds, but 2 beds are kept for emergencies, we at least have one open abdomen every day. And we are very generous in not closing the abdomens when we have any kind of difficulty. Now, of course, we had another topic given during this meeting about compartment syndromes, head to toe, from the thorax. And I'm going to concentrate only on the abdomen, not on polycompartment hypertension. Now, if you look at the incidence of intra-abdominal hypertension and abdominal compartment syndrome, I'll explain the difference in a while, it is highly variable. Suffice it to say, in certain areas like transplantation, it is very high. In burns, it is close to 70%. But look at this area here. How many of you would believe that in your medical ICUs, you have an incidence of close to 80% of intra-abdominal hypertension, 40% of abdominal compartment syndrome? Very often, this is not even found. We believe that measurement of intra-abdominal pressure is actually a fifth vital sign. And this results in conditions like oliguria, hypotension, high peak airway pressures, and multi-organ system failure. And the reason for this is very often forgotten, maybe because of high intra-abdominal pressure. Remember that a high peak airway pressure may not always be present in people. You can have an absolutely normal peak airway pressure and still have intra-abdominal hypertension. Now, very often physicians feel the abdomen and say, I don't think the abdomen, there's a problem with the abdomen. In my physical examination, I'm quite comfortable that there is no intra-abdominal hypertension. Even if God was to examine the abdomen, he or she, because God may be male or female, cannot be 100% sure that there is intra-abdominal hypertension. You got to measure it. And that measurement can be done by just taking your arterial catheter, the transducer, and putting it in. But what happens in hospitals where you don't have a transducer, you can just use the old CVP water manometer, which is quite good. But remember, when you use the water manometer, the conversion factor is very important. 10 centimeters of water is 7.7 centimeters of mercury. Most of what I will be saying would be actually in millimeters of mercury. So you can just use that if you don't have the actual transducer. And there are several catheters that are available in the market for real-time measurement, which I have shown in the slide here, and I'll certainly share more information with you, but that's a little bit expensive and I would not recommend that you buy them. Now, for a normal pressure in you and me, it's about 3 to 5 millimeters mercury. But for non-laparotomy, non-trauma hospitalized patient, it is less than 10 millimeters. So when you just say intra-abdominal hypertension, it is 12 millimeters of mercury. Anything more than 20 millimeters mercury would be called intra-abdominal, or rather would be called abdominal compartment syndrome if there is one or more organ system failure. Another way of looking at it would be the abdominal perfusion pressure. You take the mean arterial pressure minus the intra-abdominal pressure, and you can get a perfusion pressure. Anytime you have a perfusion pressure of less than 60, you get into trouble. So many ICU patients, I would recommend that you do measure this as a routine. But remember, just by raising the head end of the bed, you can increase the abdominal pressure by 3 to 5 millimeters mercury. Obesity or tight abdominal bandages, very popular with our gynecology friends, they tightly, constrict the abdomen, and it actually doesn't serve any purpose at all. And therefore, even though our normal pressure is 3 to 5 millimeters mercury, remember up to 10 to 15, we don't really get worried too much. More than 25, absolutely, it is a panic value. Between 15 and 25, a little bit of a leeway. Remember, it has to be zeroed about 2 to 3 centimeters below the pubic area, and different nurses may have different ways of measuring it. So now this concept, even though has been talked about for many years, there is an under-recognition of this syndrome, and I'm very happy that the organizers of this meeting have thought fit to include this in this presentation. Dr. Ivaturi Rao presented this editorial in Critical Care Medicine saying there's an under-recognition of this problem. In Canada, in 1999, 10 years ago, not 10 years ago, just a few years ago, they did a survey and they found that even though surgeons knew about intra-abdominal hypertension, many people at the time of initial surgery rather close the abdomen very tightly than put in a mesh or leave it open. So even in Canada, the performance is not very good. And recently, in a paper from Critical Care Medicine, there are several references here to show that in various parts of the world, it is amazing to see that people don't recognize it. Would you believe that 13% of members who belong to the Society for Critical Care Medicine in the US were not even aware that something existed called intra-abdominal hypertension? You know, they're all members of the society. And this is because, you know, people say, I don't believe in it, okay? I've never seen it. But I think we as specialists owe it to our patients to actually measure intra-abdominal hypertension. Now, once you have detected it, once you have detected intra-abdominal hypertension, let's say that like the previous patient with pseudo-obstruction of the colon, the surgeon said, I am going to close the abdomen, and the abdomen is very tight. Then a patient comes to the ICU, has oliguria, and it becomes a big problem to manage it. How do you actually manage the patient? Every patient does not have to go back to the operating room. Sedation can be done, neuromuscular blocking agents can be given, but believe me, if your intra-abdominal pressure is 30 millimeters mercury, no neuromuscular blocking agent in the world is going to get it down to normal. Maybe marginal elevation, 18, 19, 20, maybe even 25, you can bring it down a little bit, but certainly not to a great extent at all. So whenever you have a patient in the operating room where the abdomen is very tight, those of you who are anesthesiologists in the room should refuse to conclude the operation, whatever the surgeon may say. If there is difficulty in closing the abdomen shall and should be left open. No attempt should be made to close the abdomen. And patients with severe infections, damage control surgery in trauma, or when the patient is hemodynamically unstable, you shouldn't be wasting time closing the abdomen. And especially when there's infections of the abdominal wall, the abdomen should be kept open. Now, leaving the abdomen open will result in desiccation of the bowel, herniation, massive fluid losses, temperature loss, and then closing the abdomen later will become a problem because of loss of domain. However, the benefits are that you can easily access the peritoneal cavity, you can plan an abdominal wall reconstruction, debridement, and then you can drain secretions such as secretions, pus. You prevent abdominal compartment syndrome and you avoid fluid and temperature losses. Now, the traditional approaches have been, if you can close the abdomen without tension, you close it. Otherwise, you decide in your mind, I'm going to subject this patient to a hernia. How often have all of you seen patients like this where you just cannot close the abdomen? The abdomen is tight, you just cannot close it. So this brings me to the second part of my lecture, namely, if you have left the abdomen open, how do you manage that? Very often, we do what is called the Bogota bag, Bogota from Colombia, but it can be any bag made with any place. Bogota is just the name of a place. It is just a plastic bag. You can use the urology bag with high volume fluid. You just stitch the bags together and you leave the bag like this, like a silo like you use in pediatrics. And you just leave the abdomen open and bring the patient back to the back to the ICU. So this is called a silo closure, and it's quite easy, but you actually have to make holes in this so that the fluid can be egressed out. Now after that, you apply suction catheters over here so that the fluid can be sucked out. Otherwise, there's no point in putting a tight balloon-like thing in the abdominal wall. And then you take care of dressings. Once the wound has a little bit better, then you can put dressings on it. You might want to put a mesh also. And because this is not a surgical group, I'm going to not spend too much time on the technique, but except to tell you what the surgeons will do. Now, after some time, you have a giant hernia like this, correct? The traditional way, a giant hernia. And sometimes the hernia looks like this. Would you believe this patient is alive, but then you have a huge hernia? What is the quality of life here, correct, on this patient who had an open abdomen? And what surgeons will usually do is, they'll try to pinch the skin. This takes about 6 months or so. At 6 months, then the patient is taken back to the surgery, and then various techniques are available: fascial approximation, or component separation where the fascia is actually lengthened, or a mesh is used. And so 1 year later, this is done. This has been the traditional approach. After 1 year, after living with a huge hernia, the patient is okay like this. Now, a new method of treatment is the vacuum-assisted device. Little expensive to use, but we have always been using different versions of it. This is nothing but a sponge. If this is an open abdomen, we have a sponge with a little skirt-like bag here, and then we have these little sponges that go on. And then if this is put on the abdomen and this is sucked out, then what happens is all the secretions from inside the abdomen are sucked out. It's called vacuum-assisted closure, useful not only for the abdomen, but useful for various wounds. In fact, all wounds nowadays in most countries in the US and Canada and other places where can afford it, this is what it is. This is what is used: vacuum-assisted closure. And here, for example, the bowel is open here, and the vacuum-assisted closure is affected. And every 3 or 4 days, this black sponge is taken out, and then it is replaced. And it is the same way in which it is replaced and carried out with a little bit of a suction. Now, this leads on to the new method, which you must really encourage your surgeons to do, which is early definitive abdominal closure. And one of the benefits of the Iraq-Afghanistan war is that surgeons have become more and more confident about using it. Very impressive results. And of almost 1,300 battle-injured soldiers, 30% had open abdomens. In about 90% of cases, the abdomen could be closed primarily. Now, what surgeons will do when the abdomen is open is after 2 or 3 days, the patient goes back to the operating room very often. And if he finds that the abdomen can be closed after 2 or 3 days, that is fine. If you cannot close it, then a mesh is put in over here. This is a 2-layer expandable mesh called a Gore-Tex mesh that is put in. And then every day, as the swelling in the abdomen goes down and down, towel clips are put in between the 2 cut edges. You remember the big edge, the big mesh that you saw earlier is now a narrow mesh. Towel clips are put in, or sutures can be put in, and every day it is brought closer and closer together. It may take about 10 days or so. And then finally what happens is the surgeon would say that this is the maximum I can do. So you put in a small mesh and the abdomen is closed. Lo and behold, the abdomen is closed. And in this study, they found that early definitive abdominal closure could be achieved in close to 90% of cases. No complications, no enterocutaneous fistulas. But very important for management of the open abdomen is pain control with epidural anesthesia, because you keep loading the patient with morphine for pain control, you're going to have more ileus, more distension, like you heard from the previous talk. Ventilatory support when needed, but you do not need neuromuscular blockage at all times. And another thing, which is the favorite topic of mine, is early enteral feeding. You cannot feed these patients. You cannot help these abdomens to close unless you feed the patient. Now, early enteral feeding with an open abdomen, you need not wait till complete closure of the abdominal defect. Now, in the past, we used to say, and these guys used to work with me in Augusta, where I was trauma surgeon, that you usually wait for 15 days, you give parenteral nutrition first and then enteral nutrition. Now, our confidence has built up so much that we do not use parenteral nutrition at all. We use enteral nutrition from day one with an open abdomen. Now, ladies and gentlemen, I want to share with you a child somewhere in war zone in Iraq who grabbed a toy from a field, except the toy turned out to be a hand grenade and blew out the abdominal wall here. And this child had this open abdomen and the sponges were put in. After a long time, this was skin grafted. Why am I showing you this slide? Because from war zone, the young surgeon there sent an email to the senior surgeon at Walter Reed Hospital in Washington, D.C. to say I was manually able to place a nasojejunal feeding tube across the pylorus into the jejunum. And I tell my residents, if a young surgeon in war zone can think about enteral feeding in a patient with open abdomen, why are we not doing it in our tertiary care hospitals? Why are we not doing it? It is quite possible. The science is very clear. For 100, 200 rupees a day, you can feed the patient. You don't need TPN. Now, when you feed a patient with an open abdomen, remember that there are significant protein losses and up to 3 grams of nitrogen. That is, that 1 gram of nitrogen is 6.25 grams of protein, so close to 30 grams of extra protein should be given in patients who have an open abdomen. Now, here is an algorithmic approach. In the operating room, should an abdomen be kept open? Well, you look at the hemodynamics, abdominal pressure is measured, anesthesiologist should refuse to close the abdomen if there is pressure. If it is fine, then standard closure. But if it is if these conditions are not there, then standard closure. But if these conditions are present, intra-abdominal pressure is high, then you ask yourself if the fascia is healthy or no. If the fascia is healthy, then serial closure. If the fascia is not healthy, then you must have a planned ventral hernia. So that concludes my presentation, ladies and gentlemen, of intra-abdominal hypertension, and I'm happy to tell you I kept my time.